Okay, guys. So we're talking about how. So we're discussing how does an infection kill, or how do infections kill or cause mortality. So we said that we have defined what an infection is, and we know that an infection can progress to sepsis, and sepsis can remain sepsis, just sepsis, or can complicate into septic shock. Septic shock is a complication of sepsis. Not all patients that come in with sepsis will come in shock. There are those that will just remain here. So, septic shock is not an integral part of sepsis. It's a progression. Obviously, you'll be more worried with a patient who is here compared to a patient who is here. And septic shock can go on into and cause multi-organ dysfunction, which we are going to talk about briefly, or multi-organ failure. And this is when death now is very imminent, unfortunately. So this is why it's important to define things the way they are. So from this, we can clearly understand why someone who's got an infected pressure ulcer is not necessarily in sepsis. And we are going to talk about the management briefly of these different patients. So, as we defined earlier, that infection is an invasion of a pathogen. So that invasion of a pathogen when you look at inflammation, infection at a cellular level and at a molecular level, you'll understand that actually the cause of problems, or the cause of death, or the cause of complications when it comes to an infection is not really the pathogen itself, but is the response of the immune system to the pathogen. So it's the response that is the problem. Just like in allergic conditions. In allergic conditions, the allergen is not the issue, but the immune response to the allergen is the problem. Just like in other autoimmune diseases, the problem is the immune system. Just like here, as much as a pathogen, the presence of a pathogen is the one that triggers the response of the immune system to that pathogen and cause all these problems. But still, the pathogen is not the one that actually causes all of these in some cases. So you've got that pathogen that triggers an immune response, And we did talk about the inflammation, which is an immune response, and the issue of having a flood of immune cells now that the cells that go to the site of the infection. One of the things that happens there is the release of those cytokines that we spoke about. Some bacteria, they also release their own toxins. Let's say bacterial toxins. Bacterial toxins. So, in some cases, you have a pathogen that has initiated an infection, but that pathogen, that infection ends up affecting distant organs. Say this infection is in the leg, or is in the back, or is in the buttock, or is in the toe. But this person who has got an infection in the leg ends up dying because of the infection that is in the leg. And that person died because they got a multi-organ failure. How did that infection from the leg ends up affecting distant organs? And it's not that the bacteria enters the blood system and they go and multiply in that organ. It's not always the case, or it's not necessarily the case. The toxins are the ones that cause the problem. The cytokines are the ones that cause the problem. I mean, I've seen a few patients that develop bacteremia. They develop bacteremia, but they are still asymptomatic. So the presence of a bacteria in the blood does not always mean that you're gonna get symptoms. And infection, this thing is very complex. Like I said, that there are patients that have bacteremia, and when the blood culture comes back, you are shocked that there's a bacteria in this person's blood, and they're not sick. And you ask yourself what's happening, and it's not that the technique was not sterile. The technique was sterile, but it's just that the patient has got bacteremia, but they just don't have symptoms. And then you've got someone who doesn't have bacteremia, but they are showing symptoms. So it's this issue of toxins. And we did say that so we did say that this response to the infection, this release of these cytokines in the form of your interleukins, which there are so many of them, I think plus minus 20 of them that have been identified, and then also these toxins. Once these cytokines and toxins, remember, we said that one of the things that cytokines do, there are those cytokines that are vasodilators. And once you get vasodilation or vasodilatation that is localized, you get hyperemia, you get that warmth, which are the cardinal signs of inflammation. But once this systemic, okay, let's talk about that after discussing this. Let me just discuss this before. I'm sure some of you have been itching to find out the difference between these. So when you've got an infection, you just have a localized sort of like inflammatory process. Localized inflammatory process. No systemic signs. Sepsis now is when there's a presence of systemic signs. Systemic signs. Now your temperature goes up. Temperature goes up. And the issue of shock. Septic shock is a type of distributive shock. When you've got shock, you know that you've got a tachycardia, you've got a decreased blood pressure, you've got hypotension, and basically, obviously, you are going to have a high temperature there when you've got shock. When you've got organ failure, when you talk about the brain, you can have a patient that appears with a low GCS. So these are the manifestations. For the brain, low GCS, they might come in with confusion, they might come in restless, they might come in with some disorientation, they might come in coma. That's for the brain. And then for the heart, like we said, they may come in with a tachycardia, with hypotension, and when you deal with the critical care, you have to specify if your hypotension or the hypotension that the patient had, whether it needed inotropes or not. There's hypotension that responds to inotropes, or there's a hypotension that responds to fluids. There's hypertension that requires inotropes, but when it comes to septic shock, it doesn't respond to just fluids. That's already a patient that needs inotropes. That's a patient that needs to be in ICU. So they can come in with basically that in terms of the heart, and the reason why they get the hypotension is because of a couple of reasons. One of the reasons is that once you get systemic vasodilation, which is what septic shock does, septic shock gives you a systemic vasodilation. Okay, let's get back to that formula. BP is equals to cardiac output multiplied by peripheral resistance. So we say this patient has got hypotension, which is a low blood pressure, and the reason why they've got that hypotension is because they've got a reduced peripheral resistance because of that systemic vasodilation. And another thing, some infections interfere with the conductivity of the heart, some toxins, bacterial toxins, but the most important mechanism is that vasodilation. Imagine if we've got inferior vena, what's this thing? That's one of the mechanisms actually. You develop a dilatation of your inferior vena cava, and that causes a reduced venous return, and that causes a reduced preload and a reduced stroke volume. That's how you get to affect your cardiac output now. So that's that with the heart. And then when now your kidneys also they have joined in, they are also affected. Now the patient starts to, or they have oliguria. Oliguria. And they also get, when it's severe, they get anuria. And this is the patient that if you aggressively give fluids because they are in shock, they will go into pulmonary edema, then they will die from the pulmonary edema. And then they get into AKI, renal failure. And when your liver is involved, your transaminases, they go up. Transaminases, they go up, and now you start having an increase in your INR. You start now having a problem with your, so the main things there is your AST and your ALT. Once they start to go up, I mean, once you develop a low albumin, that's like your chronic liver problems now. But the acute thing that can happen, that will happen with sepsis, is your elevation of your transaminases. And sad thing is, the bowel also kicks in the form of what they call AMI, acute mesenteric ischemia, which is also bad. What other organ? I can't think of any other organ now, but these are the organs that are in trouble when a patient has got septic shock, which means whenever we've got a patient who's got septic shock, our tests, as much as we are trying to look for the infection and all of that, doing the basic bloods, our tests should also be to look for the, yes, I forgot the lungs. Your patient will just keep desaturating, no matter how much oxygen you give them. The assets, they just do not improve. So they will have a tachypnea, increased respiratory rate. They will have an abnormal ABG. They will desaturate, or let me say low sets. They will have, yeah, they'll have a low partial pressure of oxygen in the ABG, and yeah, so those are your organs that become involved. So why are these organs involved? That's what I wanted to talk about now. So briefly, what we are saying is that you get an infection, it's localized, it's in the leg, it's fine. the patient is not showing any systemic signs, that patient is a candidate to go home, depending on the maybe we should talk about this after this session. This is why you find the patient is going just an infection, they are sent home on antibiotics, topical, and sometimes even oral, and that kind of a thing. Then they are sorted. They're given a review date, they come back, they are fine. But the minute you have systemic signs, that's when you should be worried. Because you don't know at what point are you going to shift from this to this. And then once you get to this, once you get here, already septic shock is an ICU patient already, most of the times, depending, most of the times should talk to the ICU doctors. But when you get here, definitely it's an ICU candidate, that patient. So, and then death results because one or two of these organs have failed and they cannot be restored. You will find now in ICU, all of a sudden, this patient is being dialyzed because of renal failure, and then this one is operated because of that acute mesenteric ischemia. Because once the bowel is dead, most of the times it's dead, and it's going to be a source of infection. Just needs to be cut out and all of that. And now this one needs to be incubated because they just keep desaturating. So these are the things. And at this point you can even get seizures there in this patient. They can even come in with seizures. So infection should not be taken lightly. And when we assess patients who have got an infection, vital signs, they become very vital, and how the patient appears. This patient is going to look sick as well. He's going to look unwell, this patient. So when it comes to a patient with an infection who looks unwell, it's not enough to just do your FBC, UNE, all this kind of CRP, all those things. Okay guys, we've got 22 minutes in this video. Let's meet on another video as we finish up. Thank you.